Hi everyone, good day to you all. I am Dr. Ma'an Al-Marzouk from Massa University, Faculty of Dentistry. I will welcome you all to this webinar conducted by Faculty of Dentistry, Massa University, that is broadcast in YouTube, Massa University YouTube channel, Massa University Facebook page, and Massa Faculty of Dentistry Facebook page. Today's webinar is about intriguing intricacies of lasers in orthodontics. Today we have a guest speaker from India. Our speaker for today is Professor Dr. Shahul Hamid Faizi. He is the Dean and the Head of Department of Orthodontics and Dentofacial Orthopedics from Satyabama University Dental College and Hospital from Chennai, India. Prof. Shahul obtained his BDS degree in 1996 from Annamalai University and obtained his Master of Dental Surgery in Orthodontics in 2001 from Savita University. Professor Dr. Shahul has 22 years of specialty teaching in orthodontics for undergraduates and postgraduate students, and he had guided various research projects for postgraduate students as well. Prof. Shahul is now Chief Conveyor of Madras Orthodontic Study Group from Chennai. He had presented scientific papers and has invited as a guest lecturer in various national and international conferences and had many publications in national and internationally acclaimed journals. Please welcome Prof. Dr. Shahul, our guest speaker for today. A very good day, sir.
Hello, good morning. Sorry, good afternoon, everybody.
Thank you for accepting our invitation for being a guest speaker for us today. Thank you so much, sir.
Thank you so much, sir, for the warm introduction, and I'm really delighted to be here. And thank you so much, the organizing committee, for giving me the opportunity to share my views about lasers in orthodontics.
Thank you, sir.
Shall I start, sir?
Yes, sir. The floor is yours. So, would you like to share your slides?
So, good morning, everybody from India, and good afternoon, everybody from Malaysia. I am Dr. Shahul. Thank you, sir, for the kind introduction once again. And I also want to thank the organizing committee, and I'm definitely delighted to deliver my guest lecture here. This is the university. Where I'm privileged to work, is Satyabama Institute of Science and Technology from Chennai. In this presentation, I'll be talking about the intricacies of dental lasers in orthodontics. Intriguing mean arousing the curiosity of interest, and intricacy means complicated details in lasers, and that's what. So the orthodontic industry constantly gives us new tools, techniques, and technologies to accomplish better treatment results without adverse effects. Likewise, in recent years, there has been a growing interest and innovation in the application of lasers to a variety of medical procedures. And consequently, different laser systems have evolved in response to varying needs. Most orthodontists are familiar with the term laser, but don't really know much about their applications in orthodontic practice. This presentation will introduce elements and properties of dental laser systems, then its various applications in orthodontics, and finally show some illustrative cases documenting better treatment approach. We all know that laser is an acronym for light amplification through stimulated emission of radiation, and its introduction has created a revolution in the history of medical science. A brief history of laser. It was Einstein in 1917 who first proposed the theory of stimulated emission, the process which made lasers into reality. And in 1962, Robert Hall developed the first diode laser. And in 1964, Kumar Patel, who is an Indian actually, invented carbon dioxide lasers. And in 1985, Pagdiwala tested erbium lasers on dental hard tissues for the first time. But only in 1998, FDA approved diode laser for soft tissue surgery. For the benefit of the students who have logged in here, and I wish to touch a little bit of basics of lasers and how the laser device works, and how the interactions between the lasers, light, and the soft tissues, oral tissues are. So let us see some elements of laser. A laser device consists of an optical cavity on which there are four principal components. They are active medium, excitation mechanism, optical resonators, that is reflecting mirrors, and a cooling system. Active medium defines the type of the laser. It can be either a gas like carbon dioxide or a solid like yttrium aluminum carbonate. And there is an excitation mechanism, is an external source which excitation mechanism is an external source that elevate the active medium for the production of photons. It can be either a flash lamp or an electromagnetic coil. Laser light generated by the stimulated active medium is bounced back and forth by the reflecting mirrors. One side of the mirror is totally reflecting, and the other side of the mirror is partially reflecting. And the opposite, so that there will be a concentration of the laser light, and this is how the laser works. So let us see some physical science behind the laser. In quantum physics, when an atom is excited, its energy suddenly rises to a next higher level. And if a photon or a light bundle is sent to this excited atom, the atom falls to a lower energy and emits a second photon, identical to the first one. In laser, these excited atoms are put between two reflecting mirrors and they get replicated. This chain reaction is called stimulated emission, and this is how laser works. This is just a brief about the different interactions the laser can have with tissues. The oral cavity is a complex environment, we all know, where hard and soft tissues exist in close proximity. All oral tissues are amenable to laser treatment, and the laser light delivered to target tissue may undergo reflection, transmission, or scatter or absorption based upon a number of factors. The degree of absorption of laser energy will vary with wavelength and power output of the laser, which can be selected by the clinician. This depends upon the optical characteristics, that is, optical characteristics of the tissue. These optical characteristics of the tissue are called chromophores. Now, if you see that the laser light has four different interactions with the target tissue. For example, it can reflect, which will cause little or no absorption or no thermal effect on tissue, and it can transmit as well. That is, the laser light transfers to the tissue without any interaction or injury to the tissue present before that. For example, a classic example is, we all know that we do laser treatment for our eye correction, eye power correction, and like that. But you know that to do a laser treatment for the correction of the eye of ophthalmic lens, the laser light is passed through the cornea. But the laser light will not affect the outer layer corneal surface, but it will have interaction on the lens inside. And this is how the laser transmission property of the laser can be used. And there is also a scattering, that is, light travels in different direction and absorbs over a greater surface of area. But our main area of concern is this absorption. That is, the laser light is absorbed by the tissues, and the light energy is converted to thermal energy. And this is how the laser works on our soft tissues and hard tissues. Again, this mechanism of action on laser interaction, I want to repeat the same, because you have to understand the fundamental basics for the benefit of the students. So the laser energy of specific wavelength is absorbed by the pigment of the intended tissues called chromophores, and its absorption varies depending upon the water content in the dental structure. That is, you have to understand this, please. Laser with shorter wavelength is well absorbed in soft tissues, and likewise, laser with longer wavelength are more interacted with the hard tissues like enamel and hydroxyapatite. This graph has four lines. That is, the red line and the brown line denotes the hemoglobin and melanin, and the blue line and the green line denotes the hydroxyapatite and water in hard tissues. Now, this graph depicts the interaction between the laser wavelength and tissue composition. Here you can see that the argon and diode lasers, which are in the wavelength of 500 to 1000 nanometers, has the highest coefficient of interaction with the hemoglobin in blood and melanin chromophores in soft tissues, that is the red and brown lines. So they can cut the soft tissue and simultaneously coagulate blood, hence called soft tissue lasers. Whereas if you see that the erbium group of lasers, where they have the wavelength from 2500 to 3000 nanometers, has the highest coefficient of absorption for the water molecules and the hydroxy uptake present in the hard tissues. So classified as hard tissue laser. Also, you can notice that the hard tissue laser will have no interaction or very, very minimal interaction in this area, so they are ineffective. And also this soft tissue lasers are very, very have minimal interaction with the hard tissue components. So this argon or diode laser, when you are doing something with the soft tissue, you don't have to get tensed or worried that it will affect the hard tissue. So this laser interaction has an advantage, for they cannot produce unwanted effects on the surrounding tissues, and that is how the laser use of laser in intraoral cavity is very advantageous. And these are the various effects of laser. Just for information, it can be photochemical, photoablation, and photothermal. Photochemical reaction effects is mainly by soft lasers, but our hard lasers like soft tissue and hard tissue lasers will have photoablation and photothermal effect. This is again just a fundamental basics how a laser light interacts or mechanism of hard tissue photoablation. That is, when a laser light is passed in the tissue, its energy gets absorbed and brings about photothermal effect, which leads to ablation. So this is that is the interstitial water molecules present in the tissues get instantaneously converted into steam because of the high heat. This pressure created by the steam produces micro explosions, which in turn carries away the hard tissue particles. This phenomenon is called hydrophotonic effect. And this is what causes the popping sound when the laser is running in the hard tissue mode. And since this micro explosion is shorter than the response time of the nerves, patients will feel little sensation or no pain at all. And this is very useful when there is a water content in the carious lesions are increased, and allows the laser light to preferentially interact only with the diseased tissue. This is an again SEM image where you can see that the interstitial water molecules have been, there's a micro explosion here because of the laser light. Okay. So generally, success of any treatment with dental lasers depends upon these factors. That is, you have to identify the target tissue, assess correct wavelength for maximum interaction, use minimum power and exposure time to achieve desired tissue interaction, and also achieve maximum thermal relaxation to prevent collateral thermal damage. Okay. Dental lasers are broadly classified based on their level of energy emission and type of application as hard laser and soft laser. Hard laser is a collective term of all types of laser that have direct interaction on the tissue. That is, they are further differentiated as hard lasers that act on hard tissues like enamel and dentin and bone, and hard lasers that act on soft tissues like gingiva and oral mucosa and this thing. Soft lasers have very low energy level, mainly used for pain prevention and promotion of healing, like after any oral surgery or endodontic or periodontic procedures, or even for the treatment of after ulcer and even also TMJ disorders, etc. Another use of soft laser is something called laser Doppler flowmetry. It is a diagnostic tool for caries detection and measurement of blood flow in the dental pulp. Low power diode laser is used to assess the nervous responsiveness and blood flow inside the teeth. It is beneficial to assess the revascularization of Owl's tooth or traumatized teeth, or even after the orthodontic force application. This is an example of how the diode laser, soft tissue laser will look. And this has been used now in dentistry for the treatment of oral soft tissue due to their wide spectrum of biological action and high therapeutic effectiveness. It has been well documented that some applications of diode laser in dentistry are cost effective. And currently, almost 84% of orthodontists, periodontists, and even general dentists regarded the use of soft tissue laser as appropriate. And this is an example of a hard tissue laser. That is, this is an erbium YAG laser or erbium chromium OSGG laser. Is a very special instrument for the use in dentistry. It can do cavity cutting, enamel surface conditioning, etc. And uh, this mode of action is photothermal. And when you use this kind of hard tissue lasers, you can eliminate the dreaded drilling noise and the vibration of the handpiece, whining sound of the handpiece, all will be eliminated, and the patient will feel very pleasant while doing the procedure. Now we shall see how lasers aid in orthodontics in terms of soft tissue procedures like etching, bonding, debonding, and finally, we also discuss about the use of low-level laser therapy in orthodontics. These are the soft tissue applications of laser, like when we can do gingival recontouring, we can do access gingivectomy when a tooth eruption is resisted due to tissue coverage, or we can also do operculum removal when the tissue can inhibit the band and bracket placement, and also we can do frenectomy and treatment of after cells, etc., etc. So this is the another case of when we did a soft tissue laser procedure. This the procedure to expose the tooth surgically, then to bond a bracket is quite challenging for the orthodontist because of the need to maintain a dry field or to use a moisture insensitive primer, and sometimes multiple appointments are needed. With the laser, we can expose the tooth by removing the overlying tissue and bond the bracket immediately. It is because the homeostasis is achieved almost instantly. For this patient, we remove the overlying tissue and the laser and the bonded attachment, and we have bonded the attachment right away. You can see that the impacted canine of the is exposed to the laser, and notice the clear bloodless field, and the attachment is bonded immediately. This is another case of palatally impacted canine, and this is the laser parameters which we use to expose the canine. In this X-ray, you can appreciate that the impacted canine is impacted palatally, and is this we can identify with a technique called SLOB. That is same side lingual and opposite side buccal, but that's a different topic as well. But and also we can identify the projection of the bulge of the canine, and this is where we exposed the palatally impacted canine. You can see that there is no bleeding and there is an adequate isolation for immediate bracket placement, and this is how the bracket is placed, and the palatally impacted canine is pulled buccally, and after some time, when you can see that the palatally impacted canine emerged to the buccal surface, we expose the canine buccally also with the same laser device, and also fix and this is how we can see that the exposed teeth is here, that is the palatally impacted canine now exposed buccally as well, and then we can fix an attachment, and then further it is brought into occlusion, and this is how we are dealing with the lasers and soft tissues. So these are the various pictures taken in various this thing, and all these pictures are the courtesy by Dr. Pramila Sugandhan. She is the proprietor of Indian Academy of Laser Dentistry, KP Medical Institute. Okay, so this is an access gingivectomy. When a tooth eruption is resisted due to tissue coverage, conventional surgical measures are related to pain, inflammation, and fear of scalpel to majority of patients. With the laser surgery, generally requires only topical anesthesia. Another major advantage of the diode is that the wavelength does not approximate, I told you before, that the wavelength of the diode does not approximate the absorption coefficient of bone or enamel. So, in other words, it can cut only the soft tissue and there will be no effect on the hard tissue. Similarly, redundant tissue for this patient which is removed, and this is the immediate post-op where you can see a clear bloodless fields. We all know that poor oral hygiene results in gingivitis, gingival hyperplasia, and also orthodontic space closure can cause gingival tissues to bulge out internally. So, excision and contouring of hypertrophic tissues can be done with diode lasers, which also produces much finer cosmetic results. This is also an hypertrophic gingival margin are often seen in orthodontic treatment, and the hypertrophic papillae are ablated and rolled gingival margins are beveled to sharpen their contour adjacent to the crown of the tooth. And this is 4 weeks later. You can see that the tissues have healed and the gingival contours are improved. Depigmentation can also be done by many methods, such as scalpel, just to remove the black band on the gums. There are many methods to do. That is, we can do some with the scalpel or gingival grafting, or with the rotary acrylic abrasives, etc. However, all these procedures are invasive and may have bleeding and pain, and it may bleeding and pain. In laser depigmentation, there are many beneficial factors, such as most often only topical anesthesia is required and no need for periodontal pack after the procedure, since minimal bleeding or post-operative pain is present. This is the freenectomy done with the diode laser and without local anesthesia, suggested by Kafas et al. The patient acceptance is good in this such kind of procedures. Post-surgical healing is optimal, and but please understand this is 2 days after post-op, and but then complex freenectomies require removal of fibrous interseptal tissues, and that should be referred to a periodontist without fail. Ankylosing will also cause inability to extend the tip of the tongue beyond the vermilion border, and due to restricted movements, patients exhibit difficulties in speaking. Laser assisted lingual freenectomy is very easy to perform, and the patients will not really reveal any discomfort or bleeding. Furthermore, unrestricted tongue movement can be spontaneously achieved. Why? Because there is no need for any sutures. Aphthous ulcer. We all have encountered patients with aphthous ulcer. Maybe sometimes we also have had a lot of aphthous ulcer in different periods of time. Aphthous ulcer are one of the recurrent problems most of the patients encounter, which may last up to 7 to 14 days. And the earlier anesthetic gels were the only mode of treatment. But such treatments only help the patient to tolerate the pain until it's cured. With the help of diode laser, there is a novel approach that can be done for the treatment of aphthous ulcer called laser bandage. After the laser treatment, patient will experience immediate pain relief, and the aphthous ulcer will generally heal or disappear approximately in 1 day or after the laser treatment. This is called laser bandage. We also do upper clear can be successfully removed the soft tissue laser. This is very much beneficial for the tooth when it resists eruption due to tissue covering. Pericoronitis also we can do. Conventional is a established method. However, bleeding and painful healing might even cause trismus. And but then laser excision during orthodontic treatment is beneficial, for it allows earlier banding of these teeth since there is no bleeding. And this is how a sample of how a scalpel excision would appear. You see, the notice how much bleeding will be encountered, and that's the problem. This is a small video to demonstrate the laser versus scalpel excision. This is again for the education purpose, I'm just telling you. An interesting part of the clinician's learning curve is to realize that the laser energy is to realize that the laser does not cut like blade. Instead, the tissue is ablated by the laser energy at the fiber tip. The proper technique is not to press the fiber and drag it along the margin to cut, but simply to guide the fiber along the precise route desired and to let the highly directed laser energy to do the work by ablation. Ablation means, I tell you again, it means the cellular temperature of the tissue is raised rapidly through the absorption of laser energy, and the tissue will eventually vaporize. And this is another side of the tooth where you can see how the scalpel excision will cause so much of bleeding, and you can see the previous tooth where the laser excision had no bleeding at all. This is just a video to demonstrate the difference between the laser versus scalpel. So the advantages of soft tissue laser: minimal or no anesthesia injection is needed. The cut is more visible because the laser seals off the blood vessels, leaving a clear dye field. Since it's a bloodless surgery, reduces the chances of infection and reduce the mechanical trauma, so no need for suture. It's a minimal post-operative pain and swelling is present because the inflammation and the bleeding is lesser, and so collectively it's a more relaxed appointment if you do any laser soft tissue procedures. This is a hard tissue use of. Now we move on to hard tissue laser. In hard tissue laser, we can perform a lot of procedures like cavity preparation, crown preparation, or even as far as an orthodontics concerned, we can do laser etching. Yeah, this laser etching, how it is happens is because this laser energy instantly boils the water content in the enamel, and this high pressure steam will cause explosive vaporization of the water molecules, which modifies the smooth tooth surface, and that's called ablation. So this laser is this has been proclaimed that this type of laser conditioning, laser enamel conditioning, will cause similar to type 3 etching pattern, that is as described by Stevenson et al. We also did a study with how the laser conditioning of enamel is effective for orthodontics. It has been postulated that the laser with the laser conditioning, when you do a laser enamel conditioning, the penetration depth is lesser, the surface roughness is better, and it also, more than anything, the surface morphology is similar to the etching pattern. So we did a study in our department, and also we published it to evaluate the influence of erbium, chromium, yttrium, scandium, gallium, garnet, that is ERCR, OSGG, laser irradiation to evaluate the penetration depth and surface roughness and surface morphology. We found that the laser irradiation produces favorable etching pattern, and the micro irregularities are suitable for resin penetration. Hence, laser etching can be preferred over conventional phosphoric acid etching on orthodontic moment. So this is how the SEM images of the this is the SEM image of the phosphoric acid etching, and this is the etching of the laser etching, almost similar to the phosphoric acid etching. So we found that the surface roughness is lesser, and also the enamel surface laser system showed that type 3 etching pattern. We also did another study to know the evaluate the demineralization resistance of the shear bond strength by using laser enamel conditioning. We all know that the direct bonding of brackets has evolutionized the clinical practice of orthodontics. But the most common method of enamel preparation is phosphoric acid etching, we all know. But however, acid etching removes the fluoride-rich surface layer of the enamel, thereby causing demineralization, which makes them more permeable and prone to acid attack. This has been suggested as one of the main reasons for the high prevalence of white spot lesions after orthodontic treatment with fixed appliances. So alternative conditions have been tried to prevent this, but all these methods fail to achieve adequate bond strength and to resist intraoral forces. When we did this laser enamel conditioning, we found that there are statistically significant difference in the enamel dissolution, resistance to enamel dissolution, and there is a maximum bond strength was achieved with the acid etch group, but there is also an acceptable bond strength which is around 9 megapascals and 8.3 megapascals with the laser etched group. What is the mechanism underlying the demineralization resistance of the laser? So this is because of the reduction in carbonic content and modification of the organic matrix of the enamel. In lace enamel, the intraprismatic and interprismatic spaces that act as ion diffusion channels during the demineralization process were blocked. That is the main important thing. So this is the making an enamel less vulnerable to mineral loss. Okay. Now we also had an adequate bond strength, that is Major and Smith have recorded, and they also Reynolds also proposed that the bond forces is from 6 to 8 megapascals is enough to is adequate for the enamel so for the orthodontic brackets to bond and for the orthodontic treatment. Hence, it can be inferred that the laser may be preferred over acid etching. That is how it is thinking. So this is how the image of how the difference between the SEM image of the phosphoric acid and the laser etched enamel. And this is also, you can see, this is an atomic force microscope scan of the enamel surface, which reveals that the laser etched enamel has more sharper craters and than the acid etched enamel surface, and this will have more bond strength. So the other big this is an example of how an acid etched enamel will be affected because of the enamel demineralization and the white spot lesion. And this kind of attacks, this kind of problems can be eliminated with the laser etched enamel. And this is again, I told you, the acid etched enamel, the pores are open. The enamel pores and the rods are have open pores, and this is very critical for the demineralization. But even here in the laser etched enamel, you can see that the enamel pores are blocked. So when it is blocked, this is becomes the reduces the susceptibility to caries attack, and the surface area becomes acid resistant. Open pores and the blocked pores. Again, a summary of the laser etching and conventional etching. You see the bond strength is quite similar to the acid etching, but only what you have to do is that the calcium dissolution and phosphorus dissolution is much lesser in the laser etching. Okay, skip this. So, in conclusion, we can say that the hard tissue laser treatment can be proposed as a possible alternative for the conventional phosphoric acid etching in orthodontic preparations. And these are all the references to support my claim. We can also do laser bonding with the orthodontics. We can use the argon lasers, and this is similar to the conventional light curing. But only thing is the curing time with the laser is only 3 seconds per bracket. That is very beneficial. And the more again the greatest advantage is to potential to reduce the enamel decalcification and prevents the formation of white spot lesion. So laser debonding. I think if some of the if any orthodontists are here, they will know that the ceramic brackets will have increased bond strength and might increase the potential for enamel damage and bracket fracture while debonding. So this will cause toothache during debonding. Generally, the adequate force to debond a bracket is supposed to be 6 to 8 megapascals, but the debonding of ceramic brackets can reach to up to 20 megapascals, which can cause enamel cracks like this, enamel cracks and tear outs. So, to prevent these complications, laser-initiated debonding mechanisms were developed. The mechanism of laser debonding is because of the thermal softening or thermal ablation, which will soften the adhesive. So the time spent to debond the ceramic bracket is less than 4 seconds. This is the video to demonstrate the laser debonding. First, the bracket around the band strength is evaluated. You can see that the head is shaking. Then it is laced for 3 seconds and we glide the laser along the divings of the slot bracket. Our concern is the rise of the intrapulpal temperature, but most of the studies show that it does not increase because more than 1.8 degrees and it is safe to use. And now we can see after the laser ablation how easily the bracket is removed with a tweezer. Now we'll talk about the low-level laser therapy. Low-level laser therapy has proved to be an invaluable tool for the dental specialists. It was Dr. Henry Mester in 1961, a Hungarian physicist, who first hypothesized that a monochromatic laser could help speed up the healing of soft tissue injuries. The concept behind this is photobiomodulation, that is, use of light energy to elicit biological response. There are many advantages of low-level laser therapy, like anti-inflammatory effect, accelerated healing effect, less post-operative discomfort, etc. But our area of concern is how that it accelerates the rate of tooth movement in orthodontics. Generally, you all know that the tooth movement through orthodontics occurs as a mechanical force acting on the teeth, resulting in a series of biological change. Approximately the time period required for orthodontic appliance is 2 to 3 years. Due to this long duration of treatment, patients neglect orthodontic treatment and tend to discontinue it sometimes. So, decrease orthodontic treatment by increasing the rate of tooth movement is the need of the hour. Earlier, many methods have been tried to enhance tooth movement, like injecting chemical agents like prostaglandin and osteocalcin, or by corticotomy, and or by distraction osteogenesis. However, all these procedures have some disadvantages. They are cumbersome, technique sensitive, cause pain and discomfort to the patient as they are invasive in nature. So we did a research to investigate the effect of low-level laser therapy on orthodontic tooth movement. We selected a total of 13 patients undergoing orthodontic treatment with a mean age of 21 years, and the study protocol was being accepted by the Institutional Review Board. After the leveling and aligning, the anterior and posterior segments were consolidated except for canine on both sides. So what we did is this low-level laser therapy was done with the diode laser of 940 nanometer wavelength operated at 1 watt output with the energy set at 80 joules. We irradiated 5 areas around the canine. This is actually a split mouth study where one side of the, in the extraction case, one side of the canine is laced, the other side of the canine is kept as control and not laced. So the 5 areas are mesiocervical, distal cervical, middle third, and then mesial and distal apical areas of the teeth. The other side of the canine is kept as control, so no laser was applied on the control side. Canine retraction was done with a coil spring with 150 grams of force. And this is a white light scanner we use in our study to digitize the models. It is a non-contact optical scanning device in which a 3D scanning process is done by a white light source. It is very, very accurate. So using the scanner, the casts obtained before retraction, that is T1, and after 2 months of retraction were scanned and converted into a three-dimensional model. And these three-dimensional models are superimposed using the software to measure the precise canine movement using a triangulation method, something like the GPS locating us. So the measured values were very accurate, and the reproducibility of the white light scanner is between 1 to 5 microns. We found that as you can see in this table, the most of the patients on the canine movement is more on the lace side and then on the non-lace side. In fact, for many tooth movement, the movement is almost doubled. Okay, so this is we found that the movement of the teeth on lace side is 2.76 millimeters in 2 months, whereas on the non-lace side it is only 1.5 millimeter in 2 months. This accounts to approximately 43% increase in the rate of tooth movement. So this our result was in accordance with the Cruz et al., Yusuf et al., Dosimeta et al., who all said that the low-level laser therapy can accelerate orthodontic tooth movement. There are many theories have been postulated in literature about the mechanism of action of low-level lasers. The most common discussed theories are bioluminescence theory, that is, laser may accelerate DNA replication via photonic stimulation. There's something called cellular oscillation theory. There's another theory where this electromagnetic oscillation of the laser beam swing and excite the tissue cells, which eventually intensify the biochemical process of every cell. But the widely accepted theory is the photochemical theory, which states that the supply of biostimulative light energy to body cells will induce biological response through energy transfer. That is, the cellular photoreceptors absorb the low-level laser light and pass it on to mitochondria, which stimulates the production of cell's fuel. The cell's fuel is always called as ATP, adenosine triphosphate. Also, Stein et al. Reported that the low-level laser irradiation promotes proliferation and differentiation of human osteoblasts. You can appreciate that the osteoblast cells are proliferated in the laser irradiated cells and then the non-irradiated cells. Osteoblasts and osteoclasts are very important thing for our bone remodeling, and the bone remodeling is the vital principal effect for orthodontic tooth movement. So, from the results obtained in our study, it is prudent to conclude that the low-level laser therapy significantly hastens orthodontic tooth movement in humans. Therefore, it can be considered to shorten the treatment duration. There are numerous studies undergoing around the world to show the effect of low-level laser therapy. Like this, they increase the interleukin 1 level and it enhances the tooth movement. And low-level laser therapy can repair inflammatory root resorption, etc., etc. It also reduces the pain during orthodontic tooth movement, increases the stability of many implants, and so on and so forth. Like this, many research has been going around the world for to elicit the response of the low-level laser therapy and the photobiomodulation, biostimulation, molecular effects of low-level energy, and rate of tooth movement, influence of low-level laser therapy in relapse, in like that. Fine. So finally, we will see some disadvantages. Like a laser light beam of a small diameter is dangerous for the eyes. It is mandatory that no one should stare into the laser light. Please be aware that the use of normal sunglasses rather than wearing a true laser lens protectors tends to increase the risk of eye injury. That's because the filtration mechanism of sunglasses is nil. The darkness of the sunglasses makes the pupil dilate to let it more light, and they provide a false sense of security. So another this is the proper, so proper safety measures are very important, like the eye protection. The patient, the clinical staff, and any attenders must wear a protective eyewear specific for the wavelength being used. And these goggles have an optical, now for example, these goggles have an optical density of 4, and this optical density was in accordance with the 940 nanometer wavelength, which is what we used in our study. So it allows the penetration of laser only 0.00001%. So this is very safe when you are using a laser light. And these are the different types of optical density classes used for different types of lasers. This is what we used in our study. Another laser thing is plume control. Laser procedures create a plume that may contain hazardous microflora sometimes. So standard dental high-speed evacuation is necessary, and good quality masks need to be worn by the clinicians. And of course, you should have this warning sign in and around the operative field to caution the attenders about the use of lasers in the operative field. So generally, there are some very important laser operating deliberations where the clinician basic surgical skills should be remain paramount. So knowledge of the anatomical site is very important, and sound diagnostic skills is necessary, and appreciation of the desired post-surgical outcome is necessary, and you have to understand the patient's dental and medical history. So the appropriate nature of any pathology should be assessed prior to surgical intervention with laser. That is very, very important. In brief, laser assisted surgery should follow strict guidelines for best practice approach as employed in conventional therapies. In comparison to scalpel incisions, laser cutting heals no faster. Please understand that. But may be more predictable through the control of bleeding and bacterial contamination. Laser assisted surgical sites heal by secondary intention. So, care should be observed when using lasers in areas where there is close approximation of various hard and soft tissues to avoid unwanted thermal damages. As orthodontists become increasingly focused on aesthetics, new tools can greatly improve the quality of the treatment results. The laser parameters such as power, pulse mode, and correct proportion of water and air are crucial to achieve optimum conditions in the ablation rate and desirable outcome. So, any clinician interested to use dental lasers in practice should definitely attend the accreditation program, which is offered frequently in various locations. This is my department, my colleagues in Satyabama. I'm grateful for them for their support. And this is my email ID and my mobile WhatsApp number. So if you happen to come to Chennai, please feel free to contact me. We'll be happy, more than happy to help you. And I owe an enormous debt of gratitude and sincerely express my thanks to Dr. Pramila Sugandhan, Director, KP Institute of Laser Studies, for her expert advice and encouragement throughout our research and permitting us to utilize her hard tissue lasers and soft tissue laser equipments. She runs a world-class laser institute associated with the International Academy of Laser Dentistry. We do periodically conduct courses and to take up the latest laser into your dental practice. So, and if you needed any, we can also, if you can contact this email address or the phone number, if you want any laser course to inculcate laser practice in your dental fraternity. And if the institute wills, we can also come to your place and conduct a 2-day hands-on training program. So thank you all so much for the patient listening, and thank you once again so much for the uh, thank you so much for the opportunity to meet you all. Over to you, sir.
Okay, yeah, so muted. Thank you so much, sir, for your informative presentation.
Thank you, sir.
Thank you, sir. I have few questions from the audience, sir, if you don't mind.
Yes, sir.
Okay, there's one question. With laser etching, can white spot lesions completely eradicated?
Yes, sir. Actually, it needs a long-term study, and it has been postulated that the laser will alter the enamel calcium phosphorus ratio in the enamel. So this is very. It will not completely eradicate, but once it is formed, it cannot eradicate. But what you can appreciate is that the incurrence of white spot lesion can be reduced drastically because the enamel demineralization is lesser and the enamel dissolution has been prevented by the acid attacks.
Okay, thank you for the answer, sir. Another question, please. During laser etching for bonding, is it necessary to etch the whole area to be bonded, or the complete tooth surface needed to be etched?
Yeah, there are different schools of thought regarding that.
Mm.
Some say that you can only etch the area of where you are going to bond, and some says that you can etch the whole tooth surface area. Generally, what we advocate is we cannot precisely locate the area of etching before bonding, before keeping the bracket, because the placement of the bracket should be with the long axis of the tooth, and if the tooth is rotated or tilted, we may have to off center the bracket and angulate the bracket depending upon the design correction. So generally, as a word of precaution, we can avoid etching on the upper one third of the tooth, that is the gingival portion of the tooth, and also the incisal portion of the tooth, but we can etch the whole middle portion of the tooth. Etching with even phosphoric acid or the laser etching will not damage the enamel very much. It is only a zero point 0.3 microns or something like that. It will be altered. So it is safe to etch the middle portion of the tooth completely. We can avoid the cervical portion and the incisal portion.
Okay, so you do selective etching
Yes.
for the tooth to be etched. Okay.
Yes.
Another question, sir, if you don't mind.
Yeah,
Okay, with
definitely.
okay, sir. Thank you, sir. With soft tissue laser after frenectomy procedure, how is the scar tissue formed and how is the success rate?
Yeah. See,
Yes.
when you do any soft tissue procedure with the laser, the best advantage is you will have no bleeding or very, very minimal bleeding, which is easily controlled, and it doesn't need a suture. Generally, after frenectomy, when we do with the scalpel, something like that, when we do suturing, that will restrict the lip movement and it will slow down the healing. So this, when you do a laser procedure with the for the frenectomy, you don't need a suture, and the scar tissue formed. Yes, the scar tissue. Sometimes there are studies that some scar tissues delays a little bit of healing of the frenectomy site, but generally the healing is uneven full, and the scar tissue formed will vanish in no time.
That's good, sir. Thanks, sir. I have a question from our live stream from YouTube. What is the
Yes.
underlying mechanism of increased tooth movement due to LLLT?
So once again, please repeat the question, sir.
What is the underlying mechanism of increased tooth movement
Yes.
due to LLLT?
Yes, sir.
Yeah.
That is the low-level laser therapy.
Yes.
There are, as I explained in my presentation, sir, there are many theories have been postulated for the low-level laser therapy accelerated tooth movement. One is they say that there is some photobiomodulation, and there is something called cellular oscillation theory. I will, if you don't mind, I will just I will, I will just put that. Okay. So there is something called bioluminescence theory and cellular oxidation theory. But the most accepted is the photochemical theory, that is the supply of biostimulant to light energy body cells will
I
induce
understand.
biological response through energy transfer. So this is how. the low level laser therapy is helpful for the accelerated tooth movement.
Yeah, noted, sir. Thanks.
Hope it answers the questions.
I hope that answered Dr. Tijazwin question.
Yes.
Okay, sir. Thank you so much for your answer, sir. I can just add one last question
Yeah, no
before
problem.
we wind up the webinar, sir.
Yeah.
During impaction, after laser treatment to expose the impacted tooth, how is the soft tissue scar is compensated for gingivitis? Is there any literature to support?
Um, okay, there are a lot of literatures to support the existence of the gingiva. Maybe I can, if you can, maybe I can mail you the many literatures which are supporting the laser excision. But
Yeah.
generally, the scar tissue which is formed after the this thing is intact only, because we are not going to encroach on the biological width of the any tissues, and we only create a window to bond the impacted canine. We're not going to totally excise the tissues. So just to the window to create enough size to bond the bracket. And the major advantage, as I told you, is the instant coagulation of the blood vessels as you cut the soft tissue. So there, where you can see a bloodless field. Generally, in orthodontics, after the to bond the impacted canine is the biggest challenge. Only because we don't have the isolation of the enamel. It will constantly bleed, and we have to use a moisture insensitive primer, or we have to wait for the bleeding to subside. But in when you do a laser exposure, a laser gingivectomy to expose the impacted canine, it is very beneficial, and it is very awesome. If you have to see it to feel it.
Mhm. Great, sir. Sir, I have a comment by Dr. Tijazwan again. He
Yes,
said,
sir.
but because of photobiomodulation, there is increased bone formation known. How it accelerates tooth movement? The question was about
Yes.
he asked about the LLLT.
Yes, sir.
Yeah.
Sir, the
What
actually
is
it
that?
is biomodulation. It doesn't mean that the bone is formed earlier. There is actually when you see that when there is a tooth movement, there will be a lot of reactions, and the around the periodontal ligament will be initiated. There will be, that's our common basic pressure tension theory, where you apply force, and on the tension side the bone is formed, and the pressure side the bone is resolved. That is the bone formation and resorption is done by the osteoclasts and osteoblasts. So what this low level laser therapy does is it stimulates the action of both osteoblasts and osteoclasts, so that the bone remodeling in total is done more, is accelerated. And when the bone remodeling is accelerated, the tooth movement also is accelerated.
Thank you so much, sir,
Yes, sir.
for answering question. Okay. Okay. I think, sir, I have no more question for now. Thank you, sir. Dr.
Yes,
Tijazwan
sir.
replied, sir. Okay.
Yes, sir.
Thank you so much, Prof. Dr. Shahul Hamid Faizi,
Thank you.
for being our guest speaker for today's webinar. Really appreciation from Masa University for sharing your knowledge with us. Thank you so much,
Yes.
sir.
I'm very delighted to be here, sir. Once again, thank you so much for giving the opportunity. Look forward to more like such interactions in the future.
Yeah, sure, sure, definitely, sir. Okay. Thank you so
Yes.
much, sir.
Thank you.
So, at the end of the webinar, great thanks to our audience for listening to today's webinar. The webinar will be there in Masa University YouTube channel, Masa University Facebook page, and Masa University Faculty of Dentistry Facebook page, if you can watch it later. For any question, you can write the question in the comments, and we may pass it to Prof. Shahul later on. Please stay tuned for announcement about the coming webinars next month. Thank you so much, and have a nice day.